So good morning, everyone. Uh, this is the Chhattisgarh State Society Symposia, and we welcome all of you. This is a very important topic. Uh, it's a ocular trauma 360-degree from impact to insight. So I invite first speaker, Dr. H.R. Prasad, on his topic, uh, that is emergency management and imaging pulse. It was the topic by Dr. Harshvardhan Gupta, but Dr. Prasad is taking. As all we know, the ocular trauma is always very
Good morning.
emergency.
Good morning, seniors and colleagues. As our topic is ocular trauma, my tributary to all innocent pupils and children who lost their life in Middle East conflict. Now let's go to our topic, ocular trauma, emergency management and imaging pearls. Initial assessment and triage is the golden hour for the eye. Time is vision. The first 60 minutes post-injury represent a critical window for intervention. Immediate triage prevent permanent vision loss, airways, breathing, circulation, stabilization, rapid visual acuity assessment, pupil examination, light reflex testing, history of mechanism and timing of injury is very important to assess the initial assessment and for the best result. Mechanism of injury, understanding the trauma types, penetrating trauma, sharp object, create full thickness wound, high risk of intraocular foreign body and endophthalmitis, requires urgent surgical exploration. Blunt trauma, compressive force causing hyphema, lens dislocation, retinal detachment, may mask underlying globe rupture without careful examination. Chemical burn, acid and alkaline exposure requiring immediate irrigation. Alkali burn cause deeper tissue damage. pH testing guide management intensity. Clinical examination essentials. First, visual acuity testing, best corrected vision assessment using Snellen chart, document finger counting or hand motion if unable to read. Slit lamp biomicroscopy, detail anterior segment evaluation, identify hyphema, corneal laceration, lens dislocation, traumatic cataract and foreign body. For posterior segment examination, funduscopy, after pupil dilatation, detect retinal tear, detachment, vitreous hemorrhage, and optic nerve injury. Imaging modalities, choosing the right tools. Selection depends on the injury mechanism, clinical types, and patient stability. Each modality offers unique advantage. Plain X-ray, initial screening for radio-opaque foreign bodies, limited soft tissue detail, quick and accessible in emergency setting. CT, gold standard for orbital fractures and foreign body localization, excellence, bone detail and rapid acquisition. MRI, superior soft tissue characterization, reserved for specific indication due to longer scan time and contraindications. Indication for CT, suspected intraocular foreign body, orbital wall fracture, assessment, globe rupture, evaluation, complex trauma and multiple injuries. MRI in ocular trauma, when and why, indication non-metallic foreign body, optic nerve injury, suspected retrobulbar hemorrhage, soft tissue characterization, contraindication, ferromagnetic foreign bodies, cardiac pacemaker, metallic orbital implants, unstable patients. Ultrasound B scan, rapid posterior assessment, B scan ultrasonography offers immediate evaluation of posterior segment injury, at bedside, particularly useful when media opacity prevent fundoscopy. Emergency surgical consideration, globe rupture repair, urgent surgical closure prevent endophthalmitis and preserve vision, primary repair within 24 hours, optimize outcome, use antibiotic prophylactic, retinal detachment surgery, pneumatic retinopathy, scleral buckle, vitrectomy, depending on detachment characteristic. Early intervention prevent permanent photoreceptor damage. Foreign body removal, surgical extraction of intraocular foreign body, location, composition, and timing guide approach. Culture specimen for infection prevention. Key points: integrating management and imaging for optimum outcome. Systemic approach, history taking, clinical examination, selective imaging, timely intervention. Imaging selection, CT for fracture and foreign body, MRI for soft tissue, ultrasound for posterior segment. Surgical timing, golden hour matters. Early surgical intervention improve visual outcome significantly. Remember, always document visual acuity before any intervention. Thank you.
Thank you, Dr. Prasad. Very nice presentation about the pulse, about the investigation, and as all we know, like ocular injuries are very important, timely intervention and timely diagnosis and proper management. So now the second talk is of the topic is ocular trauma classification, the latest update by Dr. Lipi Chakravarti.
Yeah, so my topic is ocular trauma classification, the latest update. No financial disclosures or conflicts of interest. Why we need this ocular trauma classification? Because this helps in comprehension, in communication, guides management, and predicts outcomes. Before we can treat ocular trauma effectively, we must first learn to describe it correctly, and hence we need ocular trauma classification. This is a classification, the BETS classification, which we all know of. Mechanical injuries classified into closed globe and open globe. Closed globe injuries further classified into contusion, lamellar laceration, superficial FB, open globe injuries into laceration and rupture. This is that BET system, the pictorial representation. So closed globe, it is classified into contusion, lamellar laceration, and open globe into rupture, laceration, which is further classified into penetrating, perforating, and IOFB. There are some terminologies like eye wall, which means sclera and cornea. Closed globe injury means, which is a partial thickness injury, no full thickness injury. Open globe injury means full thickness injury. Closed globe subgroups are contusion and lamellar laceration. Similarly, open globe subgroups, there are some terminologies here. Laceration subgroups, penetrating injury means single laceration of the eye wall, no exit wound. IOFB is retained foreign body. Perforating injury means two full thickness laceration. So this is the BET classification of globe injury. Type, again, rupture, penetrating, IOFB, perforating, mixed. Grade of visual acuity, pupil, whether it is positive or negative, and there are zones of ocular trauma, 1, 2, and 3. This is the classification of globe injury. This is the old system which we have been learning. The new system which has come is by IGATES, International Globe and Adnexal Trauma Epidemiology Study. This group was established in 2015 to investigate and report the incidence and epidemiology of globe and adnexal trauma and its management. The group's objective was to review and refine terms from BETS and to develop terms which were not captured previously. So we have got this all myriad of terms: eye injury, retinal trauma, mechanism of injury, severe adnexal injury. These were not included in the old systems. So corneal injury, whether it is central or paracentral zones, again, they have been redefined zone 3. It has been subdivided now into 3A and 3B. Lens trauma has been introduced into ocular terminology. These were not addressed in the old classification. So the new classification, as per this, we have mechanism of trauma as sharp, blunt, mixed, IOFB, bite or burn. Associated structural involvement of lens, retina, NLD and lid. So these are the new classification. We have got some new introduction, like this is a severe adnexal injury. This is the introduction for, this is a new terminology which has come, new explanation which has come. Corneal location, central versus paracentral. As per this, zone 3A is 5 to 8 millimeter posterior to the rectus muscle insertion, and zone 3B is more than 8 millimeter posterior to the limbus. So BETS was a structural classification, or it is a structural classification. The new system, it includes mechanism plus structure plus severity of trauma. So the new terminology does not replace BETS, it just expands it. This is OTS, just an overview of that ocular trauma score. We have been following this. Initial raw score based on visual acuity, globe rupture, endophthalmitis, perforating injury, and raw score sum is the sum of raw points. This is how we calculate. I won't be going into detail. Drawback of OTS does not include associated injuries that have a bearing on the outcome of mechanical injury, does not factor in results from ancillary tests like X-ray, CT, ultrasound, B scan. So whatever the results are coming from this test, it does not include those investigation reports. Closed globe injuries such as hyphema may present with significant initial visual loss but often recover substantially. So the initial visual acuity, that is given a lot of importance in BETS, but sometimes even with decreased initial visual acuity, the recovery may be good. The prognosis may be good. So we have revised OTS, revised ocular trauma score, that consists of 5 predictors: initial visual acuity, RAPD, rupture, zone and eyelid injuries. Similarly, we have pediatric ocular trauma score. We should, as ophthalmologists, know this, the revised systems which have come into vogue now. So to conclude, in ocular trauma, classification is not just a terminology, it is the first step towards prognosis, communication, and better patient outcomes. So the patient outcomes and management that will be dealt with by the succeeding speakers. Thank you.
Thank you, Dr. Lipi, for a very good talk.
Now we invite So, good morning, everyone. And I'll be talking about the lid and canalicular laceration, about the aesthetic and functional restoration. So, eyelids, they are the structures which protect the eyes. Any disease which alters the structure or functions, it ultimately threatens the vision of the patient. And understanding the basic anatomy and physiology is fundamental for any good reconstructive surgery. So these are the different lamelles, the anterior and the posterior lamella, important landmarks which we should remember while proceeding ahead. The backbone, tarsal plate, some basic principles in stitchcraft surgery, like avoid inversion of the wound edge, suture from loose to the fixed end. In cases of an unequal thing, thick edge take a deep bite and thin edge take a superficial bite. Unequal height, start from the superficial and go on to the lower side. And of course, the subcuticular sutures wherever you don't need any superficial scar. The basic principles in reconstruction of both anterior and the posterior lamella, at least one of the lamella should have its own blood supply. Full thickness defect needs reconstruction of both the layers. These are the different techniques for the anterior lamellar reconstruction: the direct closure, the Z-plasty, the local advancement flaps, and the skin grafts. While the posterior lamella we can use for spacers, the scleral spacer or artificial spacers are also available in the market. Direct closure has to be done along the Langer's line. The different flaps, advancement flaps, rotational flap, transposition flap, the length of the flap should be less than 3 times the width of the base to apply vascular supply at the base. So this is an example of a transposition flap, a rotational flap, Now, according to the size, defects up to 1/4 of the lid length can be closed directly without addition of tissue from elsewhere. However, up to half of the lid length, you need release of tissue from somewhere like lateral cantholysis or a semicircular Tanzel's flap or a macrosal flap. Tension should always be in the horizontal plane. Now, different techniques, because of shortage of time, I'll skip through these slides. Lateral cantholysis. It helps whenever the small defect, go for a lateral cantholysis, close the defect directly, and then form a lateral canthus. The semicircular Tanzel's flap, it works well for both upper and lower lid, while a bigger defect, up to 75 or 100% of lower eyelid, you can go for a lid sharing like Hughes flap. And this is the clinical scenario of a Hughes flap or a mustarded advanced cheek rotational flap. Now, in upper lid, the principles are the same. Up to 25% reconstruction, it can be closed directly. More than 25%, you need tissue from somewhere, release it to a lateral cantholysis or a Tanzel's or a mustarded flap. For larger, you can go for a lid sharing, that is Cutler-Bear technique. So this is what it looks like after the Cutler-Bear procedure. So quickly going through some of the clinical cases. This is a child, 10-year-old child, has a history of dog bite, and the upper lid, it's typically affected by a dog's paw. So this is what which comes to us, the tarsal fracture, the canalicular damage, and after 3 or 4 hours of surgery, this is what it looks like on table. And this is 1 month post-operatively. And if this video plays, yes, it's playing. So this is what it's a functional restoration after 1 month. So layer by layer, we have to approach in such patients. Lid marginal tear, this video is not working. What is important is that the gray line suture has to be done through a non-absorbable suture. The tarsus inside can be done through an absorbable suture. Now, this is again a child. The good part was that this video is working. The tarsal fracture was not there. It is a lid marginal tear, the gray line tear, and extending externally up to the skin. Because of the pediatric patient, we have taken Vicryl in this case. Otherwise, it's a rule that preferably the gray line suture has to be non-absorbable silk suture. So simply put a tarsal suture, keep the long ends, bury up the long ends, and then you can repair the superficial skin. This is a lady, it's a history of sebaceous gland carcinoma, histopathologically proven. So what we have done is that we have taken a rotational flaps from just above it, and then this is after the stage. The last picture on the bottom right, this is after stage 2, after the final tissue margins has been free, frozen sections was good. We have done a stage 2 reconstruction, release the base of the flap. So a careful approach has to be there in each and every cases. For canalicular laceration, important for us is very, very important is the lower canaliculus, because 70 to 80% of tear drainage occurs to the lower canaliculus. Most commonly in the pediatric patient, it is the blouse hook injury, while a trauma is always there in adult patient. So these are the different ways to manage it, different stent. And just a short video before I end my presentation. Lower canaliculus, complete tear, dilating the punctum, checking the entire pathway through a Bowman's probe, and then inserting, this is an oro stent, a monocanalicular stent. So inserting this stent, it has a beautiful sleeve which fixes up into the punctum, prevents it from it coming out, and once that fits in, the distal end can easily be inserted into the distal end of the canaliculus. And then the closure is done in layers. So this remains secure, does not come out, and after many times it is self-excluded. If does not, after 3 months you can remove it. Thank you all for your kind attention.
Thank you, Dr. Ankur. Very explained very nicely. And as we know, the role of lid is very important, because for the injury, it prevents the anterior segment component. But if it is injured, then it should be repaired very nicely. Then only the other parts can play a role. So thank you very much, Dr. Ankur. Doctor, next speaker, Dr. Sonal Vyas, but I think she is absent. So Dr. Madaria sir, traumatic cataract and lens management. This is the different. No, you just go up.
the discussion after end of each, all the lectures.
Meanwhile, if any questions from Dr. Ankur till Dr. Madaria is preparing. Any question from audience? आप लगाए ये लगा होगा लग
Good morning, respected chairman, chairperson, and the respected audience. My topic is the traumatic cataract. As we all know, after the trauma, the most important complication which we see in the lens is the development of the traumatic cataract. This is a video-based presentation. As we know, we can see in this video, there is 3 stitches are applied in the cornea, and it is a total cataract we can see, and the anterior capsule is also ruptured. So while giving the incision, we have to be very particular, as we should not further damage the whatever the remaining anterior capsule is there. As the AC is very slow, so while giving the side port incision also, we have to take a extra precaution, because while giving the side port also we can further damage the traumatic cataract which has already been developed. It is a swollen cataract and the AC is usually very shallow. So the next important step is the staining of the anterior capsule. As we all know, after the putting the air bubble, we inject the trevine blue, and once the staining of the anterior capsule is done, then the next important thing comes the capsular axis. As we all know, because here the anterior capsule is already damaged, so there is a big challenge while doing the capsular axis. Here we cannot do as a traditional triple C capsular axis is not possible. So it is a very tricky to do the capsular axis in traumatic cataract. We have cut the small portion of the anterior capsule, then with the help of the capsular axis, microcapsular axis forceps, we are making the capsular axis. As at the upper part, the capsule is already damaged, so we could make only the 3/4 of the capsular axis, we could make it. And with the help of microcapsular axis, it is only possible. And as we can see, this is a very irregular capsular axis. So we are putting a good viscoelastic, preferably high molecular one should put, and with the help of capsular axis forceps, we could try to complete the capsular axis as much as we can do. So now in the lower part it is almost circular, and the upper part it is almost the irregular. And with the help of the scissor, we could complete it in the upper part also. So because in the FECO, there is importance of capsular axis we all know is very important. Then only we can proceed the further procedure. And here only the challenge was in the making the capsular axis. So we could able to make the capsular axis almost 3/4 we could able to make it. Then the next step, as we can see, it is a soft cataract. So we did not to do the, we are not required to use the power of the FECO. We are little enlarging the side ports. So with the help of bimanual irrigation aspiration, we can suck the cortical matter. It is almost a very soft cataract. Only the cortical matter is available. There is no central nucleus is present. This is a traumatic cataract of a child who was only 14 years old. He had a trauma. So here there is no, only the cortical matter is there. So with the help of the irrigation and the aspiration, we can remove the cortical matter. As we have to be little cautious, because we should not rupture the posterior capsule. And with the help of this irrigation and aspiration, we can completely clear the cortical matter. And then the next comes this, almost all the cortical matter has been cleared up, and we are trying to do the polish also. And while cleaning, we have to be little cautious. After a small portion of the cortical matter is still left, yes, all the cortical matter has been cleared. The posterior capsule is well intact. And then the next, there is 3 stitches are present in the cornea. So we are going to remove, after this cleaning, we can remove the stitches, and then still a small amount of cortical matter is left. So while cleaning, we have to be very particular and very cautiously. Then these 3 stitches we have removed, and with the help of 26 needle, and this is also very important. This is a very old stitches are there, and all the cornea is well healed, so there is no risk in removing the stitches. And after then the next step is to put the 3 pieces, 3 piece, we have put the 3 piece Elcon lens. As we know, the upper part, there is a incomplete rhexis. So we are putting the lens in the sulcus, so it will be better. So we could put the 3-piece lens. once we are able to put in the sulcus, now the purpose is solved, and patient can now have very good vision. Thank you very much.
Thank you, Madaria sir. We'll take up the questions at the end, sir.
Okay, thank you.
Next, I invite Dr. Anupam Sahu for his talk on iris and pupil injuries, cosmetic and functional repair. Dr. Anupam, please.
Thank you, Dr. Soma. So my talk is on iris and pupil injuries, basically cosmetic and functional repair. No conflicts of interest. So different types of trauma can occur to the iris and pupil: iris prolapse, iridodialysis, iris sphincter tears, traumatic mydriasis, correctopia, or iris tissue loss or atrophy. So iris prolapse is something that has to be treated immediately. The others are basically, in fact, iridodialysis also, especially if it's done iatrogenic, and these actually lead to lots of issues for the patients, can lead to a lot of issues for patients. So remember that functional issues outweigh the cosmetic issues. Glare and halos are usually found, especially with traumatic mydriasis and such conditions, reduced contrast sensitivity if the pupil is not functioning well, monocular diplopia, difficulty with night vision. These are the major functional issues that the patient can face. So these would be the reasons why we would like to intervene in these cases. But before we intervene, we need to actually evaluate these patients to find out whether they actually, that is the major cause for the patient's complaint. For example, a slit lamp examination might reveal a corneal scar or uveitis, which might actually be the cause for the photophobia and glare. So that needs to be evaluated. AC depth, pupil reactivity testing, whether the pupil is reacting or not. I'm going to aim for a pupilloplasty, but then if the pupil is not reacting very well, it might not work very well. Transillumination defects. Iris, if it's atrophic, then do not touch that iris. It will cause more trauma. Anti-segment OCT and UBM can be done to find out what's behind the iris. Assess the lens status, zonules, posterior segment evaluation, and most importantly, the visual prognosis. If the visual prognosis is not very good, then doing all these things may not actually work to the patient's benefit. Also, the other options beyond surgery are sunglasses or glare control for those cases with milder problems, pharmacological pupil modulation, and tinted or prosthetic contact lenses. What are the principles that we need to follow while we are operating on these cases? So our aim should be to restore the pupil size or centration, preserve the remaining iris tissue, no harm to the iris, minimize inflation and distortion, combined with cataract or IOL surgery whenever needed. But then last 2 points are conflicting. So if you think that the inflammation is going to be more with the IOL, you can always put in a secondary IOL. This is the main suture that we usually use, the 10-0 Prolene. Some people also use 9-0 and others, but then this either on a straight or a curved needle is usually advised for these conditions. Now coming to different kinds of surgeries that we have. So whenever we have a sphincter tear or iris tear, then in those cases basically CPSAT showed us that how we can put a knot in the eye without going into the eye. So the knot can be placed just outside, and then once both the sides are pulled out, we can actually have a iris repair without going into the eye too much. But then it had a problem that you had to take out the loop multiple times before you actually are able to do the before you're able to complete it. So Dr. Amar Agrawal showed us that putting 4 knots actually helps. Just with one exit, the knot stays with 4 knots. So that is how the single pass 4th row is done. So you hold the iris and then you go through each part, come out from the other side. There are 2 ports, and once you tighten it, it tightens and stays in that position. For extensive sphincter damage and traumatic mydriasis, you can do the iris cerclage pupilloplasty, and Dr. Santosh had shown very well in the last CSOS conference. So multiple bites around the pupillar margin is done. All these things have to be done very carefully because these are very fine needles and they keep going everywhere. So if you are planning on doing this, ensure that you have the IOL in place, and if it's a clear lens, then be very cautious about doing all these things. Create a round and symmetrical pupil if you have done it very well. Then coming to iridodialysis, it is pretty common wherever we have SICS training, and you will find the inferior iridodialysis many a times in the initial part of our training procedure, and McCannell suture technique is what is usually followed for these cases. It's very simple. Again, it's a ab externo technique where the suturing is done outside the eye. So the modified sewing machine technique is something that we now use, where for larger iridodialysis you can actually go just once into the eye again and do multiple sutures in these kind of cases. So this just one case where I'll be showing how we will be managing this case. So I'll just okay, so after you have put in the lens and all, then you can make a groove where you need to actually insert the 10-0 needle into a 26 number needle, and then once it's just the end is out, you bend it and then you start doing the sewing machine technique. You go from one side and end at the other side. You have the needle always inside the eye. You do not need to take it out. Go along the groove from one side to the other. You have to be bidextrous for these cases because you need to use both the hands together. And once you have these knots out, so we are taking out loops out from each point, and once you feel that okay, enough iris has been taken out, you just come out of the eye. Yeah, last video. And then this end you pass through all the loops and then tie it down. So that way, just with one entry into the eye, you will be able to manage the iridodialysis. So that's it. So then we also have artificial iris implantations if you have lost iris in those kind of cases, but then always keep these complications in mind: suture erosion or breakage, iatrogenic iris trauma, loss of iris tissue, intraocular inflammation, secondary glaucoma, and corneal endothelial damage. Keep all of these in mind before we actually intervene for these things. So assess the damage, evaluate the iris tissue health, customize the approach, and both functional and cosmesis is important, but function is more important, and excellent outcomes can be achieved. Thank you.
Thank you, Dr. Ankur. Nice presentation. Our next, I invite Dr. Dilip Lalwani for angle recession, glaucoma, diagnosis, and long-term management.
Good morning, all. So, angle recession glaucoma is a most common post-traumatic secondary type of glaucoma, often missed and have a lifelong risk of glaucomatous neuropathy. So, why it is important? Because it may appear years later after blunt trauma. So, total risk is 19.8% and 5-year risk is 1.6%. This is about 6 times higher than the chance of getting glaucoma after a piercing injury. Angle recession is not equal to glaucoma. So 5 to 20% of glaucoma who have severe angle recession will develop glaucomatous optic neuropathy in many years later. So it has a medico-legal importance, and every traumatic eye deserves gonioscopy. So what is the pathophysiology? Actually, blunt trauma hit and it tear between radial and circular ciliary muscle, and it widened the ciliary body band. You can see glistening white scleral spur, and it will have a chronic trabecular damage, will may cause glaucoma. So if more than 180-degree angle recession, it is a high risk to develop a glaucomatous neuropathy. So when to suspect? If any previous history of sports injury, blunt trauma, road traffic accident, or in remote childhood injury, you have to take proper history. So how we can have a clue if at all presentation is unilateral, asymmetric cupping, or IOP higher in injured eye. Associated finding you may or you may not have, like hyphema, iridodialysis, sphincter tears, traumatic cataract, or phacodonesis. So here we can make a diagnosis by gonioscopy only. You can see here ciliary body band is widened with a bright scleral sphere, irregular angle structure, and we have to document extent in clock hours and compare with the fellow eye is must and mandatory. So you can also see here how radial and circular muscle fiber is tear and give a widened ciliary body band. This is a radial tear. So what is the difference between angle recession and cyclodialysis cleft? In angle recession, only tear between radial and circular muscle fiber, but in cyclodialysis, whole ciliary muscle complex is detached from scleral spur. You can see in right side of photo, this is a widened scleral spur. So what will do investigate? IOP monitoring with diurnal variation, optic disc evaluation, visual field, RNFL and ganglion cell complex study, and if needed, ASOCT UBM. So we have to classify. I already told if more than 180 degrees, that will make a high risk to make a glaucomatous neuropathy. It may with or without raised IOP or with or without glaucomatous damage. So management, if no glaucoma at all, you have to only annual lifelong follow-up, So if glaucoma is present, first go for medical. So angle recession is a diagnosis, glaucoma is a possibility. So come to the medical management. Aqueous suppressants are the best treatment, like beta blocker, alpha 2 agonists, and topical CAIs. Second comes the PG analogs, which will be effective in chronic cases by increasing UV scleral outflow. And in acute cases, inflammation control, we can take the use of topical steroid and cycloplegics. Miotics should be avoided at all, and laser, SLT or ALT has a limited role. If at all it is not controlled or progression is there, you can opt for trabeculectomy versus tube or shunt procedure. So trabeculectomy has a higher failure rate, so you have to use antimetabolite in all cases. Second is tube shunt is preferred because it has a better long-term control, and choice depend on specific cases. If rapid or dramatic drop in pressure is necessary and conjunctiva is healthy, TRAB is almost, it might be preferred. But significant scarring, previous history of operation, so tube shunt will be best choice. So here we can conclude angle recession is not a glaucoma. We have to take long-term follow-up, and gonioscopy is mandatory after blunt trauma. And more than 180-degree recession is a lifelong risk, and will deal with a medical management first. If not at all control, then tube prefer, then trabeculectomy. Patient counseling is a crucial. Thank you very much.
Thank you, Dr. Lalwani, for a nice talk. Now I invite Dr. Santosh Singh Patel. Topic is traumatic endophthalmitis from despair to vision salvage.
Thank you, ma'am. Good morning, respected dignitaries on the dais and off the dais. Today is my presentation on the traumatic endophthalmitis. It is a very devastating ophthalmological condition and present in 15 to 30% of the open globe injury. It is a management challenge for the surgeon. Type and nature of the injury intraocular foreign body, and pathogenic organism all influence the occurrence of the endophthalmitis. The variety of spectrum of the microbiology involvement, culture positivity in anterior chamber 28%, vitreous step is 33%. The factor each independently associated with the development of the endophthalmitis is delay in the primary repair, rupture lens capsule, dirty wound, and highly virulent organism. Clinically presented with pain, proptosis, eyelid swelling, chymosis, elevated intraocular pressure, corneal involvement, anterior chamber reaction, hypopyon. Intraocular gas bubble can be attributed to a Clostridia or B serious infection. For the investigation, we need B scan for the rule out of the intraocular foreign body, vitreous involvement, retinal detachment, or all cases of the visualization of the posterior segment. CT for the intraocular foreign body identification, MRI for the non-metallic foreign body evaluation. And for organism, we need appropriate culture, stain, and the PCR technique. For the management, there are different controversies, like it is useful to empirically give the intravitreal, or intravitreal can have a complication. About the systemic, it can diffuse or not, or what about the phakic. So for the prophylaxis, we should give all systemic, periocular, topical, all antibiotic prophylaxis for the all globe laceration, because of the blood retinal barrier breakdown, it improves the antibiotic penetration in systemic also. For the systemic, intravenous Venco and Septa, and for oral we can give Getty, Levo, or moxifloxacin. The eye should be carefully followed in hospital setting when we have not given intravitreal, or there is no foreign body, or no sign of the endophthalmitis. We should not send the patient for the OPD basis. Intravitreal antibiotic therapy should be given in all suspected traumatic endophthalmitis, in all cases of the IOFB, and mostly in the B series cases, because this is a very virulent organism and high risk of the endophthalmitis. Steroid should be avoided initially because it may mask the clinical signs. There are very publications showing the intracameral or intravitreal antibiotic reduces the risk of the endophthalmitis. For the active management, when foreign body is absent, we can give Venco, Amica combination or Septa for the intravitreal, subconjunctival, topical, and systemic. For the oral, we can give Levo, Getty, or moxifloxacin. When foreign body present, we can give clindamycin and amikacin or ceftazidime for the intravitreal, subconjunctival, topical, and systemic. Prednisolone can give after the initiation of the antibiotic therapy. For fungal endophthalmitis, we can give amphotericin B and voriconazole for the intravitreal. For subconjunctival, better to use miconazole or amphotericin. For topical, natamycin or amphotericin or voriconazole. And for systemic, better to avoid the systemic toxicity of the amphotericin, use ketoconazole or voriconazole. The steroid should be omitted for the fungal management. So for the intravitreal injection, this should not repeat except in case we have the positive repeat culture. Reserve the adjunctive conjunctival, subconjunctival, and topical therapy for the significant anterior segment inflammation. For the fungal, we should start when fresh smear or positive fungal culture. Avoid the amphotericin B and can give ketoconazole. Now come to the vitrectomy. It is an advantage of the opportunity to obtain the vitreous sample, clearing the media, remove the intraocular inflammatory toxins, and remove of the intraocular foreign body. Whether the disadvantage is rapid clearance of the intravitreal drug and chances of the retinal breaks and detachment. So it is always better visual outcome when we have performed the vitrectomy within 24 hours of the presentation. It is also required when there is a worsening after 24 to 48 hours of the after intravitreal, so we should go for vitrectomy. Vitrectomy is associated with the intravitreal therapy for the all fungal cases. More virulent organism ultimately need vitrectomy, so better to start early after the culture or stain. For the IOB, need vitrectomy urgently. For inert or non-organic, we can wait for the inflammation subside and then we can remove the IOB later on. So this is the case with the intraocular stone particle removed with the vitrectomy and at the end given intravitreal antibiotics. Prognostic depends on the poor visual outcome factors are the delay in diagnosis, delay in primary repair, rural trauma, virulent organism, and associated ocular injury, IOFB, primary eye implantation, and the retinal detachment. So in summary, prompt collection of the vitreous or aqueous sample for proper evaluation with the different imaging, antibiotic prophylaxis by all modality, careful followed up, intravitreal therapy for all traumatic endophthalmitis, vitrectomy whenever required. Limited vitrectomy is preferred to minimize the risk of the iatrogenic retinal break. Intravitreal steroids for the inflammation control only. Repeat culture and avoid of the repeat intravitreal injection whether it is not required. Recent advantage, we have a new drugs like imipenem we can use for the resistant organism, and we should reserve for this some publication from the LVP also to use a provident iodine in the infusion fluid for the prevention of the endophthalmitis. So in conclusion, further advances in the microbiology like PCR and another fluorescence modality, provident iodine, intravitreal antibiotics, improved vitrectomy instrumentation with availability of silicone oil, newer alternative antimicrobials contribute to better outcome for the patient with traumatic endophthalmitis. Thank you for your kind attention.
Dr. Anand Saxena, for the concluding talk, his topic is When the Retina Fights Back. Thank you, Dr. Santosh, for your nice presentation.
Thank you, sir.
Thank you. So, this is the major cause of preventable monocular blindness and visual impairment in the worldwide, especially in developing countries. Ophthalmic trauma constitutes 7% of all bodily injuries and 10 to 15% of all eye diseases. The International Globe and Adnational Trauma data from India of September 2022 shows mean age of patients is around 31 years, 78.3% of them being males. Road accidents constitute 11.6%, workplace related injuries are 20.8%, fireworks 1.8%, and sport related 6.2% of these trauma cases. So it's just some terminology according to the trauma classification. So it's either the close trauma, contusion, lamellal laceration, open globe injury, rupture, laceration, penetrating and perforating injuries, intraocular foreign bodies. So among the non-penetrating injuries, the sequelae from blunt trauma affecting the posterior segment include commotio retini, choroidal rupture, chorioretinitis scleropteria, macular hole, posterior vitreous detachment, retinal breaks and detachment, retinal dialysis, vitreous hemorrhage, traumatic optic neuropathy, optic nerve avulsion. So in the whole, if you want to see in the picture, you can see all the kinds of complications in the closed globe injury. So commotio retini is the damage to the ocular retinal layers caused by shock waves that traverse the eye from the site of impact following the blunt trauma with foveal involvement. A cherry red spot may appear because of the ischemia surrounding the retina of the surrounding to the macula. The treatment is in most of cases it is self-limiting. The steroids can be tried. Foveal involvement may have chronic visual impairment due to development of RPE atrophy and hyperpigmentation. Patient is asked to return if symptoms of RD are experienced, which is common in some cases. Choroidal rupture, when the eye is compressed along its anteroposterior axis, tears may occur in brook membrane as well as in the overlying RPE and fibrous tissues around the choriocapillary. There are two types: direct, located anteriorly at site of impact and run parallel to ora serrata, and indirect, where it occurs opposite to the site of impact. So treatment, there is no medical or surgical therapy is given in the choroidal rupture. Amsler grid chart must be given, and any changes in the grid should be reported immediately, since a change may indicate the development of CNV. CNV is common with such kind of the choroidal ruptures. In the presence of CNV, antivascular endothelial growth factor injections can be used. This chorioretinitis, exculpatoria, simultaneous break in the retina and the choroid that occurs as a result of high velocity object passing adjacent to the globe without penetrating the eye. Large areas of choroidal and retinal disruption combined with extensive subretinal, retinal or vitreous hemorrhage, as the blood reabsorbs, the injured area is repaired by the extensive scar formation and widespread pigmentary alteration. The macular hole may appear immediately or several days after the trauma also. OCT can be at identifying the progressive retinal changes leading to development of macular hole. The treatment depends on some closes spontaneously and some do require pars plana vitrectomy with membrane peeling, and intravitreal gas tamponade is the primary therapy. The posterior vitreous detachment not indicated unless no any treatment is indicated unless the associated with the acute retinal break, lattice degeneration or dense vitreous hemorrhage. You can just identify it clinically by the B scan or by the OCT. The retinal breaks are often multiple and they are commonly found in the temporal quadrant. The treatment is prophylactic laser therapy is essential to prevent retinal detachment. The treatment of the retinal detachment patient with acute RRD, treating macula need urgent surgical repair. If there is the macula on, you must go immediately for the surgery. RRD of macula can be repaired within a week, and chronic of macula RD are treated within a week or may take some time. But if the macula is on, must be operated immediately. The retinal dialysis is a tearing of the retina at the ora serrata due to the avulsion of the vitreous base from sudden traction at the vitreous base. When a dialysis occurs in the superior or nasal areas, trauma should be strongly suspected. The treatment part without an associated retinal detachment, observation, laser or cryotherapy should be considered. If retinal detachment is present, vitrectomy with scleral buckling and cryotherapy is essential. The scleral buckling should be done in such kind of cases. For the vitreous hemorrhage treatment, the bed rest is the first with the elevation of the head. If vitreous hemorrhage obscures the view of the posterior segment, B scan or radiologic ocular imaging should be considered given. The traumatic optic neuropathic classification is direct anatomical disruption of optic nerve due to injuries to the face, head and orbit by the projectiles, indirect by deforming forces applied to bony orbit or motion of globe where the optic nerve absorbs energy concentrated in the orbital apex. The optic nerve head fundus are initially normal with pallor of developing over the subsequent days. So treatment is only steroid can be given in very initial days when the disc is pink. If it optic atrophy settled down, then any treatment is of no any use. The optic nerve avulsion is the rare manifestation of blunt trauma characterized by the separation of optic nerve from the retina, choroid and vitreous, with lamina cabrosa being retracted from the sclera. No damage to optic nerve sheet is seen. The diagnosis is easily when fundus is clearly visible using 90D lens or indirect ophthalmoscopy in hazy media, ruling out optic nerve atrophy is necessary to prevent the unnecessary use of steroid. No specific treatment is required for that. The penetrating injuries considered primary closure. The general principle is the management of penetrating injuries to the eye include the primary closure of the wound, removal of any foreign body, prevention of secondary complications from the injury, anatomical and visual rehabilitation of the eye, protection of the fellow eye, general rehabilitation of the patients. The intraocular foreign body, the presence of IOFB increases in the risk of endophthalmitis. A prompt surgical removal may be associated the decreased risk of the clinical infections. And for the investigation point of view, this the localization of the foreign body with the CT scan is the only tool. You can see just with the B scan and clinically also. The traumatic endophthalmitis is the common when the crystalline lens is damaged or there is the intraocular foreign body. Dr. Santosh Patel has
Dr.
explained
Saxena, can you
in the
summarize it,
detail.
please, first?
Thank you very much, sir.
Thank you, sir. Thank you, all the speakers, for your enlightening presentations. Now we invite for the questions. We would like to thank and congratulate Dr. Lalwani for his efforts in getting this session in AIOS. So, any question?
Well, I have a question. Maybe we can start serially with Dr. Madharia, sir. Sir, in your video, you showed corneal suture removal before IOL insertion. So, should it be done after IOL insertion, or why it was done prior to IOL insertion?
You are correct. We can do after IOL insertion also. But at the stitches were applied 2 months back. It was operated somewhere else. So what I think after the end of surgery, if I remove it, so it will be better. There is no problem.
Any more questions for Madharia?
Yes, sir. How long it took time for the cataract to develop? Was it there during the initial injury, or did it develop later?
Actually, patient came to me after 1 month.
Okay.
That time he has developed the cataract.
So primary closure was done somewhere else?
Yeah.
Okay.
Yeah. So that time the wound was not completely healed up.
Okay.
So I do not want to do any further interferences.
B scan was done, sir,
Yeah,
to rule out
yeah,
RD
yes,
and all.
yeah, B scan
And A scan, how did you do the A scan for this child?
I took the keratometry reading of the other eye because this eye was having high astigmatism because of the 3 stitches were there. So I took the keratometry reading of the other eye and I applied this number which was calculated in the other
eye. Okay. And what was the post-op vision of this child?
Post-op, he developed after a month 6-9.
6-9.
With correction of the astigmatism also because he developed the astigmatism as well.
Okay.
So, suppose patient is coming with the corneal tear and traumatic cataract. So, what is your suggestion? When do you operate like cataract? After primary repair or the same setting?
Yeah, if your cataract is fully developed, so first we should do the primary repair of the cornea. Then once the if chamber is not compromised, so what happens in some cases, if the cataract is fully developed, the chamber is very shallow, then the likelihood of the developing the secondary glaucoma, in many cases of the traumatic cataract, we find the secondary glaucoma they also develop. So if there is no development of the secondary glaucoma, the chamber is well maintained, so in that cases we first do the primary treatment of the corneal repair. Then we can do later on. And if we are thinking it is likely to cause the secondary glaucoma, so both the thing we can do in the same sitting also.
Yes, sir. Like if it is a traumatic and it can cause the phacolytic effect
Yeah,
also, so
yeah.
can repair.
Ye-
And what we have seen in a video, whenever we are repairing the cornea, so the suture should be embedded
Yeah.
because knots were open, so it should not be.
Yeah.
Usually we remove corneal these sutures after 3 months when there is a all healings happen. So
As this was suture was applied in the
yeah,
by the
that's yeah,
primary
yeah, some say, yeah.
primary surgeon.
Dr. Madharia, when the cataract has set in and the cornea is closed, shouldn't we wait more for the proper healing of cornea, other chances of dehiscence,
Yeah. Yeah.
while you are using some pressure inside the eyeball? So they recommend 6 weeks to wait.
Sir,
The cornea fellow will confirm it.
here the 2 months was over, sir. So
You said 1 month, that's why I asked. Na? Acha, any preference for
no,
IOL?
one month he came 1 month
1 month
after
later.
repaired to me. I again waited for 1 month for further.
Okay, okay. That's nice.
Right.
Any preference for IOL and
Sir,
with region?
as the child was of 14 years old, so I used the hydrophobic only.
Okay.
Yeah.
Thank you.
Thank you.
The next is Dr. Anupam Sahu, next speaker. So one quick question, sir. Iris prolapse, you talked about iris injuries. Iris prolapse, I would like to know that in which cases excision should be done and in which cases we can wait.
Thank you for that question. So, because Dr. Sonal is not there, I was expecting her to treat that thing. So, this basically would fall into the domain of our cornea, so emergency treatment. I believe within 24 hours, it can be this thing, but then beyond that, I think Dr. Dipshika Agrawal would be the better person. I send these patients to them. They come back to me later on.
Okay, madam can.
Okay.
Excision versus.
Okay.
So,
So
iris
if iris prolapses, then if it is more than 24 hours, we have to excise the tissue and do the cornea repair. And if it is very like within 2 or 3 hours, we are seeing and if the iris tissue is okay, then we should deposit. So that is the thing. And I have a question.
Madam, sometimes we see a conjunctival
Over, yeah,
covering. Yeah.
yes,
So then can we remove the conjunctiva
Yes,
and then reposit?
no. Then of course it should be abscissed and then yeah. Because if conjunctiva is over, that means ki already the time is gone. So I have to abscisse. And I have a question with Dr. Anupam, as he is a pediatric ophthalmologist for the pediatric cataract, like traumatic pediatric cataract. What would be your preference, the IOL implantation and
IOL.
what the position?
Yeah. So basically, if in this case astigmatism was high and there are already sutures, so in these cases, if because this is not actually the other eye, once the scar is formed, then it actually becomes a different eye. And for a 14-year-old, amblyopia is not that much of a concern right now. So many a times we advise for a secondary IOL implantation. So treat the cataract, do a posterior capsulotomy along with that, as because there will be chances of increased inflammation. And once that is done, then as a secondary stage, because once you remove the sutures and all, you'll find that actually many a times the astigmatism settles down. So that is something that can be done as a secondary stage. So I usually do a posterior capsulotomy with a vitrectomy in these cases most of the time. And third would be that, as sir has said, that the hydrophobic 3-piece IOL would be the most appropriate lens for these kind of cases.
Do you
That
advise removing the sutures at the same sitting?
No, I don't. I send
Yeah.
that to the cornea people. They remove that and then I do the surgery. So, but if it's a ruptured IOL, what I do is that within 1 to 2 weeks of the suturing done, I remove the IOL and then I send it back to them for the suture removal, because finally we are going to give a long-term vision to that child, as make the eye as good for the child as possible. So 2 to 3 interventions is okay as long as we give a good final outcome for that.
Will you put the IOL in a sulcus or this is capture?
So that's why I do the posterior capsulotomy, because by the time we are going to put in the IOL, there will be fibrosis. But then if you have a large enough, so I do a 6 millimeter capsulotomy. Once you have that, you will be able to capture it in that fibrosed membrane that is already formed. So once you do that, you have the lens actually in the position where it should be, as in the bag.
So thank you. I think time is over. So thank you to all speakers, audience, and thank you.
We
We'll take a
again
photo.
thank the participants and the speakers. We invite you all to come on the dais to have a group photo. कुछ लोग कुर्सी में बैठे हैं तब तो बनेगा।